Welcome to GynoCurious. Today's show is a solo act. Please send any comments to radiofreerhinecliffe.org, or if you're interested in my clinical practice, please go to dramynovatt.com. So today we're talking about urinary tract infections, or UTIs, because they are one of the most common bacterial infections affecting women. This episode covers what they are, why they happen, how they're diagnosed, and modern microbiome-centered approach towards treatment and prevention that moves beyond the just take antibiotics. So, why is this topic important? Why does it matter? UTIs affect an estimated 150 million people worldwide each year. In the U.S. alone, 10.5 million office visits, 2 to 3 million ER visits, and $3.5 billion a year economic burden on this country for this diagnosis. Each of us as women have a lifetime risk of greater than 50% of having at least one urinary tract infection, and the risk increases with age. Approximately 10% of women over 65 have had one, and 30% of women over 85 report a UTI in the past year. So what is a UTI? It's an infection anywhere in the urinary system: the kidneys, the ureters, the bladder, the urethra. And most UTIs, when we talk about them here today, but also in your doctor's office, we're really talking about the lower urinary tract, the bladder and the urethra. A recurrent UTI is defined as more than 2 episodes in 6 months or greater than 3 episodes in 1 year. Now, this is different and distinct from a relapsing or persistent infection, which is when the initial therapy wasn't completed or effected. So again, you can have persistent infection or recurrent infection. They are different. So what causes these infections? There's kind of an old storyline, and then there's newer science. The old storyline is that bacteria traveled from the GI tract to the rectum to the periurethral area, up the urethra into what we thought was the sterile bladder. This led to decades and decades of hyper-focus on hygiene and wiping habits, never well supported by science, I'll have you know, and a whole industry of feminine hygiene products. Our new understanding is the female bladder is not sterile. It's actually a host of a complex microbiome like so many other aspects of our human body. Urinary and vaginal microbiomes interact along with bladder mucosal immune mechanisms to influence infection risk. E. coli remains the most common pathogen overall, and in premenopausal women, a healthy urogenital microbiome is dominated by lactobacillus species, which helps block pathogen colonization. So when lactobacillus species drop, the risk of E. coli colonization and cystitis increases. In the postmenopause, the declining estrogen levels leads to a decline in lactobacillus, which again increases pathogen risk. But what's interesting is up to 35% of recurrent UTIs in the postmenopausal woman is not an E. coli infection. So there are microbiome shifts, different bacteria that will be affecting the bladder. So why are us women so at risk? UTIs are 4 times more common in women than men. And this is probably due to aging and declining estrogen again, and a shift in the vaginal microbiome. Anatomy: the urethra of a woman is shorter than that of a male, so there's less distance for bacteria to travel. And interestingly enough, there are birth control techniques like the diaphragm and spermicides that tend to raise the risk of bladder infections. But general overwhelming risks are also dehydration, constipation, incomplete bladder emptying, congenital urinary tract conditions, urinary tract blockages like kidney stones, suppressed immune systems, catheter use, and recent urinary procedures and surgery. So why do we care? Well, if these infections are left untreated, they can lead to kidney damage, if one is pregnant, preterm delivery, and sepsis, especially in the older woman. So how is the UTI diagnosed? For many, they're aware of what's called a clean catch. This is a midstream collection after wiping with an antiseptic. But more often than not, you might do just a generalized urine dipstick in the office where we check for white blood cells and red blood cells, nitrites and leukocyte esterase. And what we know is that these urine dipsticks are very good for ruling out infection, meaning if they're negative, it's unlikely that you have a bladder infection. A positive result, however, can be a false positive, so you need to go on for further testing, and that's usually a urine culture. This identifies the specific bacteria and guides antibiotic choice. Of note, if you're being told that you have mixed flora as a result, this is contamination. This is not a bladder infection. It's really important that you not treat mixed flora. Imaging like ultrasound, CTs, MRIs can be helpful for recurrent UTIs to look for obstructions, change in structure, and cystoscopy. The scope of the inside of the bladder and the urethra, again, particularly good if somebody's having recurrent cases. So what are the symptoms that women will often describe? They'll describe painful urination or dysuria, urgency, frequency, suprapubic pain, and the diagnosis is typically these symptoms combined with bacteria found in the urine sample. It's challenging sometimes because an overactive bladder and vaginitis can mimic UTI symptoms. And in young women, what's interesting, science has demonstrated that empiric treatment for symptoms alone, so the onset of acute dysuria without vaginal discharge, so those two symptoms combined, is greater than 90% accurate for a UTI diagnosis. So again, in the era of telehealth, if you're having symptoms of acute dysuria, but you do not have vaginal discharge, then it's very likely you do have an infection in your bladder. In older women, we don't want to just give empiric treatment because there's a risk of overtreatment. Testing is recommended. So again, urine dipstick, clean catch, urine culture. And certainly if you're a person who's had recurrent UTIs, guidelines recommend urine testing at each acute episode before treating. So we are thinking about the microbiome so much in today's science. And like so much in medicine, treatment shouldn't be a one-size-fits-all. We really want to avoid the overuse of antibiotics. We want to avoid antimicrobial resistance, the risk of C. difficile infections, disruption of healthy body microbiome by overuse of antibiotics. There's an increased risk of vaginal yeast infections. And also, what's interesting is that science has demonstrated in placebo-controlled studies, 30 to 40% of women improved on placebo alone, no antibiotics. So you really want to have a good conversation with your primary care doctor, your urologist, your gynecologist before you go ahead and take antibiotics. And delayed antibiotic use may be very appropriate while waiting for culture results, as long as there's no signs of pyelonephritis or urosepsis. If one is going to go on antibiotics, please, the shortest effective course is most recommended, often only 3 days, generally not exceeding 7. And the first line options tend to be nitrofurantoin, Bactrim, and fosfomycin. So again, you want to try to avoid any more significant antibiotics if you have these symptoms. And there are other things that we can do. If you are in the peri and postmenopause and you're having recurrent vaginal or bladder infections, vaginal estrogen can be so helpful. Evidence for the use of probiotics is inconclusive. There's small samples and varied trials, but the benefit cannot be ruled out. That lactobacillus crispatus is especially promising, but not widely commercially available. Vaginal probiotics may outperform oral for restoring vaginal ecosystem balance. Cranberry tablets are widely used and they may prevent E. coli adhesion to the bladder wall. There's mixed evidence, but mostly helpful for recurrent E. coli UTIs, and there's low risk in using them and certainly potential benefit. D-mannose, also an oral supplement, also blocks bacterial adhesion. Again, low risk, but the evidence doesn't really support effectiveness when used all by itself. And then the prescription urinary antiseptics like Hiprex and Urex, these convert to formaldehyde in acidic urine to kill bacteria. And these are used for prevention, not treatment of an active infection. But you do have to have healthy kidney function to clear these products. And the data are still sparse. NSAIDs can be used to reduce pelvic pain and inflammation, but again, there's limited evidence of efficacy in this condition. There are emerging therapies to watch for. We're looking into immune modulating UTI vaccines and bacteriophage therapy, viruses that target and reshape bacterial populations long term. So the other thing I want to mention before we close is this phenomenon of asymptomatic bacteria. This is when there's bacteria present in the urine. So you've gone to your doctor's office and they've dipped your urine for some reason or another. You have not complained about symptoms, and they say, oh, you have bacteria in your urine and we want to treat you. Please, the consensus guidelines are do not treat with antibiotics for asymptomatic bacteria. So in closing, UTIs in women are extremely common and often driven by shifts in the vaginal and bladder microbiome, not poor hygiene. Diagnosis should be confirmed, not assumed, whenever possible, especially for recurrent cases. Antibiotic use should be judicious, shortest effective course, first-line agents, delayed initiation when safe. Prevention increasingly leans on vaginal estrogen, methenamine, and other non-antibiotic strategies rather than long-term prophylactic antibiotic use alone. And the future of UTI care includes vaccines and bacteriophage therapy, aiming to reduce antibiotic dependence. The big picture is think of UTI prevention and treatment through a holistic, microbiome-centered lens. Thank you for listening to GynoCurious. Stay well. Please listen to your instincts and intuitions. They are the greatest of teachers, not to be ignored.